afternoon. I am Gary Mintz from Cardiovascular Research Foundation in New York. To my right is S.J. Park from Asan Medical Center and the director of TCTAP. And to my left is Antonio Colombo from Milan, Italy, and Bon-Kwon, also from Seoul, Korea, from Seoul National. The topic for this interview is left main and bifurcation PCI. So I think what we're going to do is start with a series of slides presented by SJ, after which we will discuss the topics that are raised. SJ?
Thank you. This is a wrap-up slide about main and bifurcation intervention issues. The main angioplasty, anatomical and functional evaluation of the main and outcome between the bypass surgery versus PCI, future perspective of ACCEL trial, current and future guideline about the main angioplasty. What of the bifurcation angioplasty, appropriate stenting technique and depending on IVUS and FFR concern. This is typical examples, intermediate left main Ostial stenosis, angiographic quiet tight stenosis. However, FFR is 0.84. Actually, depending on FFR, negative FFR, we D for the patient, so we didn't treat the patient. Validation of a pre-procedural FFR for the intermediate left main disease, actually we have no data about that. However, still in the left main disease, FFR cutoff value, it calculated 0.74, and the practical use is 0.8 is quite appropriate use. And if we look at some mismatch concerns, anatomical and functional evaluation of intermediate left main disease, here the diameter stenosis, insignificant stenosis less than 50%, and positive FFR kind of a reverse mismatch is 23%, high degree of stenosis and negative FFR 6%, over 30% of a patient has a mismatch problems. So we have some relatively small MN IVUS ischemic threshold to predict positive FFR, and 0.75 match with 0.75 is 4.1 millimeters, and match with 0.8 4.8 millimeter scale. So we have and published some lot of IVUS guidance, especially for the optimal IVUS stent areas to prevent the restenosis, and in a case of a circumflex Ostial part 5, radiosum 6, polygon of confluence 7, and proximal left main, and so we name kind of a root of 5, 6, 7, 8 millimeters after two stent procedures can make a good clinical outcomes. It's a PCI versus surgery concern. That syntax, even syntax studies, the main subset is clearly demonstrate actually no difference at all to PCI with the Texas and CABG in terms of a MACE rate. This is pre-combat study, including the Cypher versus bypass surgery comparison, and no difference at all. We have some historical comparison with Xience V stent, with the Cypher stent. It's actually almost same behavior. So with a PCI with a second generation dual stent. So you know that the current ACES-H guideline is to a very low risk region patients syntax score less than 22, and intermediate regions to be evidence B. However, unfavorable anatomy angioplasty is good candidate for bypass surgery. Is a PCI guideline is 3B concern. And so we have some discussion points. Gary, you want to read?
Sure. So before we start on these discussion points, let me back up 2 steps, because I think that's clinically important. The first question I'd like to ask is, why do we operate on left main disease? It seems like a simple question, but we obviously operate for ischemia and I guess for symptoms, but do we ever operate for other reasons? Because, or stent for other reasons. I mean, why do we treat left main disease? I don't think it's clear cut. It's not like the LAD or the right. So, Dr. Koo, what do you think? Why do we operate, or why do we stent left main disease? What are the reasons?
Because that the ischemic burden is the biggest in the whole coronary artery disease, and although the number is not that big, the previous very early studies, so there was a big difference in mortality or the survival between the medical and the surgery. So that may be the reason why we are talking about the left main.
But let's remember, those were very few patients.
Sure.
And if they looked at the subset with normal right coronary arteries, there was no benefit to revascularization. So I think that's still an open question. The second question, and we're not non-invasive imagers, is how reliable is non-invasive imaging for detecting significant left main disease? I think we've all had cases where balanced ischemia and the thallium or the echocardiogram, with even during stress, are is misleading. Antonio, do you rely on non-invasive testing very much?
I rely, but if I have some other reason to believe that the left main may be critical, I go after this problem with other evaluations. We all know that there are other tools in non-invasive. Stress echocardiography can be quite appropriate. You see impairment or contraction, etc. One important aspect is that not rarely, left main critical stenosis patients do not have angina, but they have shortness of breath, fatigue, especially elderly patients. They come with almost impaired LV function caused by global ischemia, and they don't feel angina. The most typical situation is when you inflate a balloon in the left main. Most of the patient just goes down with the blood pressure. He doesn't complain of angina. He disappears because of global ischemia. So I think that has to be taken into account. The other point, and looking at the presentation of SJ, the FFR, I'm not completely happy when I see a left main with an FFR of 0.82. I mean, I like 0.92, but when we go to those borderline values, I like to put in perspective.
I mean, I think that gets back to my first question, is why do we operate on left main disease? Do you always need demonstrable ischemia? And so you're suggesting that you might be more liberal, if you will. You might be a little more aggressive in treating left main disease, even if it doesn't meet any specific threshold.
Yes, I mean, demonstrable, I will be very hesitant to attack a left main with an FFR of 0.9. But if the circumstances, let's say I have a lot of plaque burden, the left main lesion is relatively simple, can be treated with one stent, and the FFR is 0.81, I may lean toward doing. Age of the patient, circumstances, where, I mean, at the end we are physicians and we make a general assessment.
Okay, so you have a patient in the cath lab. You're not sure the left main severity. Do you always do IVUS or FFR? When do you rely on the angiogram alone? And if you're not sure of the angiogram, which do you pick, IVUS or FFR? So let's take each of those, because these are clinical issues. When in the cath lab do you do either IVUS or FFR for left main disease? Clearly not 100%. Mm-hmm. So what circumstance, SJ?
Right. It's in a group with the Ostial shaft lesion subset. There are no pretty much disease about the epicardal arteries. There is intermediate stenosis. Personally, I think FFR evaluation is really crucial things to define clinical ischemia, to treat or not treat concern. However, the bifurcation lesions involve the proximal, the circumflex arteries. There are some technical problem to measure the FFR, real FFR values, how much coronary fluid are compromised, and so actually practical point of view, IVUS is more user-friendly concerns in a case of a more complex lesion subset. And so the reason why we have some more correct concept about IVE's kind of MRA and functional significance relation. So Ostial chapter region, personally, I think FFR is very crucial. So, however, there are more complex region subsets. IVE's evaluation have a more understandings, more information from that.
But when is the angiogram enough? Like, for
Right.
example, you did a case this afternoon.
All right.
You did not do FFR on that left main or IVUS on the left main for evaluation. So when are you happy that the angiogram is telling you that it is severe?
Right. First of all, by angiogram concern is insignificant stenosis, less than 50%, and personally, I'd like to, very careful evaluation of a patient's symptoms, ischemic evidence, etc., etc. That is more important. It's nothing atypical one, just a little bit wrong. So, however, it's more angina-like symptoms experience. Anyways, we're going to do stills FFR less than 50%, and between the 30 and 50%, so we're going to do the FFRs.
Dr. Koo, would you tell us a little bit about the issue of FFR in left main and disease in the LAD or the circumflex? Because there are two very nice, elegant papers from Stanford that are starting to address that issue.
Right, so that it's very easy to say use IVUS for FFR in left main, but how we really use, it's more complicated, FFR in complex left main disease. We know that the isolated left main is less than 20, sometimes less than 10%. So left main disease meaning that the left main plus multivascular disease. So if there is, let's assume that the left main is 60%, LAD 60% stenosis. If we measure FFR in LAD, we are overestimating the left main lesion severity. And if we measure the FFR in circumflex, we are systematically underestimating the lesion severity. So that's the scenario. But it also depends on the severity of LAD disease. So that in a in vitro and the simulation study from the Dr. Fioren's group, they measure the FFR, change the severity in LAD stenosis, and assess the influence of that stenosis to the circumflex LAD or the vice versa. And they found that unless the LAD lesion is really significant, such as less than 0.6 something, it usually doesn't matter and doesn't influence that much on the circumflex. But assuming that if there is a critical stenosis in left main ostium, distal left main, LAD, circumflex, collateral to the RCA, then in those complicated cases, it is true to say that we cannot measure left main FFR at all.
Okay. And can I ask a question to Dr. Koo? How do you deal with the issue of hibernating myocardium? Myocardium that has been down-tuned because of chronic ischemia, so will not respond to vasodilation, and you may have to dilate the lesion in order to evaluate the lesion, paradoxically.
So that it's a very difficult question to answer, but we may have some clue from the myocardial infarction study, but it's different, right? So hibernation is different from the short-term recovery from the myocardial infarction. So I would say we don't know at this moment how we can deal with those specific so-called the hibernating myocardium. So if there's one caveat of the FFR is if there's a possibility of the changes in microvascular dysfunction or the microvascular damage, FFR can be varied. So that in patient with but the question is, we don't know whether it is hibernated or whether it is non-viable unless we treat that lesion. So that's a difficult question to answer and difficult question to be dealt in a clinical scenario.
Okay, so now let's move into the second discussion point having to do with the comparative results of PCI versus CABG for left main disease. There's been a lot of literature. SJ, you've contributed a lot. So let me ask Antonio first, because we've heard your data. Looking at all the literature, not just syntax, not just, I've always believed that you look at the totality of the literature unless you have major, more than one robust clinical trial answering a specific question. And since that hasn't happened yet, looking at the totality of the literature, what do you believe about the right way to treat left main disease?
First of all, I'm perplexed by the current guidelines, because if you look in the most liberal, it says 2A, but with low Sinter score, non-bifurcation, so everything has to be clean, but still asks that the patient has to be very high surgical risk. So, which I contend, because even the syntax data, with all the limitation of the trial, in those subgroup had even a lower mortality with PCI. Low risk and intermediate Sinter score had a numerical lower mortality. And we still penalize PCI, and we only give the green light if the patient is high surgical risk, which I think this is totally a little bit unfair. The literature, unfortunately, the only is a pre-combat and the small study from Poland, right, which with the endpoint of ejection fraction,
funny endpoint.
So I think the literature is still open, and we have to wait for the Excel result. But I think the registry data, all the data published by Chieffo are real. The Delta registry, Rotterdam, are really in favor of PCI, at least in relatively straightforward and simple left main. And if I had a left main myself, not involving the bifurcation, I will not hesitate a moment to get a PCI.
So I have a question to Antonio. So all the guideline indicates the syntax score. So my question is, how should we deal that score in a cath lab having a patient with left main disease? Should we stop and calculating the syntax score and graded the patient risk and then set the treatment strategy, or how you are practically using that number?
There are many ways, in my view, to deal with the syntax score. One way is to do FFR. If you do FFR, you automatically lower the syntax score. Second is to read the COURAGE trial. If you accept to treat some lesions medically, even if they are critical, if you have a patient with a left main, a very distal total occlusion of the right coronary artery, most probably that the surgeon would not even bypass, and the bifurcation lesion of the obtuse marginal branch, those two lesions may impact on the syntax score almost as much as the left main. But what's wrong to treat the left main and maintain medical therapy on the other lesions? I mean, why are we obsessed with these complete revascularization? I think it has to be an appropriate complete revascularization. And the beauty of PCI is that if you don't complete revascularization today, you can do it in a month, in a year, in 2 years.
Yes, Jake, what's your opinion?
PCI and CABG concern of the main disease, and look at this syntax trials. If you compare with the cerebral subset and the main subset, it's a big difference. Cerebral disease subset, they higher mortality, the higher repeated revascularization, higher MIs, and total MACE rate is amazingly higher. Is good with the PCI. However, even the main subset from the syntax studies is actually not statistical difference in terms of all MACE rate and PCI versus surgery. That means, and the other meta-analysis clearly show that the efficacy concern, hard endpoint, actually no difference at all. TBL is a higher PCI, and stroke is higher in a bypass surgery group. There is current, meta-analysis from the published data. However, what I'm thinking is the main disease is very tough reasons. However, cerebral disease is another disease entity, right? However, interventionist side, the main intervention is more, good target for angioplasty rather than the multiple, vessel angioplasty. And so, in the future, we got some, lots of expectations about the Excel trials.
Yeah.
And so, Gary, you...
Well, I'll just quickly mention the Excel trial, which is a specific trial randomizing patients with left main disease to bypass surgery versus implantation of a Xience stent. Roughly 50% through with enrollment. There are all sorts of recommendations for IVUS and FFR use, both pre-intervention to assure that the left main is severe and to optimize the stents, their core laboratory analyses, and of course outcomes. The primary outcome does not include repeat revascularization, which is, to your point, appropriate because I personally agree with you. It's not only that staging PCI or doing it over time is an adverse outcome. It's also that when it really is repeat PCI to treat restenosis, the impact on patient lifestyle and outcome of getting on the cath lab to treat in-stent restenosis is very different than having to get on the table for repeat bypass surgery. Anybody who argues that the two are even close to being equivalent does not understand, what patients actually go through. So the Excel trial, I think, we wait to see the results. It took a long time to plan. There was a lot of negotiations. Abbott's spending a lot of money on it, and maybe for the first time we'll get the answer. Anybody have any guesses what it's going to show?
I think it's going to be favorable for PCI.
Okay.
I think all the preliminary data from registries, from the SPIRIT trials, comparison Taxus versus Xience are pointing in that direction. We should not forget that even if it's not incorporated in the trial, people are using better antiplatelet therapy. So it's
so you're optimistic.
I mean, if we fail Excel trial, I have to go in Holter monitoring.
Okay. SJ, are you optimistic?
Yes, I think it's a guess. So I'm, the primary endpoint, the hard endpoints are not included in the repeated vascularization, and so hard endpoint wise, I think it's quite at least non-inferior, so maybe superior.
The guidelines are getting more and more liberal. Do you think they're going to change very much, or are they going to wait now for the Excel trial?
What do you think?
I think until we have an Excel trial, I don't think the guideline 2A or the 2B may be changed.
I agree.
Yeah.
You want to move on to non-left main
Right,
bifurcations?
so let's just spend a few minutes talking about non-left main bifurcations. And I guess I don't really want to repeat a lot of the discussion we did with IVUS and FFR, but let me ask Dr. Koo, because he's probably done the most elegant work in this area. Summarize how you use FFR in non-left main bifurcations, both pre-intervention and post-intervention. So I think there's a lot of misconception out there.
So that the pre-intervention, I usually don't measure FFR in side branch. So if main branch is okay, don't need to measure in side branch. And second thing is that during the intervention in jail side branches, in a big side branches, for example, in the diagonal branch, which if there is a 1 or 2 diagonal branches, at least 2.3, larger than 2.3, with more than 60 to 70% stenosis by visual estimation, and I do measure FFR. And after 2 stenting, or if I had to do the 2 stenting, I usually end up with the IVUS, not the pressure wire.
Okay, Esha, you agree?
Yes, I've learned after the FFR functional concept of a bifurcation, PCI. Actually, the jeopardy areas of side branch is not large usual, right? A relatively small one, and so and many randomized studies, TIMI3 flow is okay. That means a kind of relatively small myocardiums cannot influence the total clinical impact on MACE rate, repeat revascularization, etc., etc. And so after the functional concept, in the practice-wise, we've changed. Personally, I've changed a lot, and so I do not much, stent procedure for the side branch. If from the beginning there was a significant disease, we're going to evaluate it a little bit more, carefully, and then we're going to do the 2 stent from the beginning. However, the frequency is quite lower, less than 10%. So, in almost all cases, I do main branch stenting and just repeat rounds after the functional, concept.
So if you see TIMI3 flow, you pretty much don't do anything unless it's a giant side branch.
Right.
Good. Okay, so the last quick point, non-left main bifurcation trials. I actually think there have probably been more non-left main bifurcation trials than left main bifurcation trials when you put together the Nordic and the BBC and the Nordic Baltic and everything else. And my reading is that the simpler the better. What do you think needs to be done next? If you had to design the next non-left main bifurcation trial, Antonio, how would you design it? What question would you answer, or do you think we basically have beaten this?
They are not, first of all, I think you have to separate the side branches which just need to stay open with no much to be done, and even you will tolerate a significant stenosis, because even if the side branch has a significant stenosis, but if it's very small, territory of distribution relatively minimal, maybe diffuse disease, to go and dilate and risk dissection may not be worth it. So separate side branches that really may need attention from the side branch that don't need attention from the beginning. And then you are really left with not so many, because so I don't know if it's worth the trial, but if a trial needs to be done, you have to keep a priori this separation. Otherwise, you pollute the group, and you know already that in some side branches, no matter what, you will not going to do anything. And in real life, if the side branch is smallish, I will not even do a final FFR on the side branch. We have to be practical. The cost of the FFR wire in Europe is more expensive than a stent.
So what do you think about, last question, and then I think our time will be up. What do you think about bifurcation stents? We do not have them in the US. Do you have them in Korea?
No.
So you're the lone person amongst us who've had some access to dedicated bifurcation stents. There have been a whole bunch of them. What's left? Are there any that are really being used, and do you think they're even necessary?
I love progress, so I don't want to say that all this work has been done for small gain. But as I said this morning, we learned how to deal with this problem without the stents that they come almost at a late time. I will love to see an excellent bifurcation stent, but in my view, we still don't have it.
Okay. Well, I'd like to thank my friends, SJ, Antonio, and Kwon. I think it's been an interesting discussion. I think we've covered most of the important points, and we hope that you have also found it interesting. Thank you very much.
Thank you. Okay, it was good. We have to see what next year new we have to say.